So please start.
Hello. Am I
Sachin
audible
चालू
here?
कर, Sachin चालू now. Sir,
Yes, sir.
चालू कर.
Yes, sir.
Okay. So welcome once again to all of you for this MAHA IP Subspeciality, which is our program from the Maharashtra IP from last 1 year. And I must thanks to all of you for joining today in the large numbers. And to start with today, let me introduce first about what our program is and why and how we are doing it. So MAHA Subspeciality Clinic is one of the program what we are doing. It is we are calling each and every specialty of the IAP. That's like suppose for pediatrics, we have pediatric neurology, pediatric nephrology, or similar types of 12. Last year we have taken the programs and huge success for that. And I must thanks for that to Dr. Amol and to Dr. Hemant Gangulia, respected secretary and president for the last year. Your enormous efforts has made success so that we are continuing this program again for the second year here. So for today, we are actually having started with a pediatric neurology. Let me introduce first about the today's guest and guest of honors and along with the president and secretary for the MAHA IP. First of us, we have with us Dr. Ramakant Patil sir. He is the current AP member of Central IP as well as the president of Maharashtra IP. It's a unique way that he's representing both the two places with us. And enormous success for the MAHA IP conference. We have noticed it along with him, Dr. Shyam Chaudhary sir, also Dr. Milind Vardia sir, that it was one of the greatest conference. And in that conference, we decided that we'll continue with the MAHA IP Subspeciality for the another year. With us also have Dr. Hemant Gangulia sir, who is the past president of the Maharashtra IP. And he was the person who stand with this program continuously, along with the Amol Patil, who is the secretary for this Maharashtra IP. So thanks to both of you. And Dr. I also can see Jay Bhandarkar here. He was along with me last year. He was also the convener for the last year for the Maharashtra IP. And we have conducted around 12 programs last year. Every program was hit in the way that around 1,000 people used to see live, and afterwards, subsequently, another 1,000 will see it later on. And it was liked by many of the people, not only from the Maharashtra, but also from the all of the India level. So this year, we have also with us Prashant Jadhav sir, Milind Bhadia sir, and Shyam Chaudhary sir. That will be the convener for this program. Apart from this ones, we also have Dr. Chitra madam, Dr. Vishal sir, who are the backdoor benches for. These are very important people for us to have the smooth condition of this program. So with this ones, I hand over to our president, Dr. Patil sir. So for your few words about this program. And later on, this will be taken by Dr. Sachin Patil. Ramakant Patil sir, are you there?
Thank you, sir.
Yes, sir. Very joy.
I congratulate Dr. Prashant Jadhav and Dr. Shyam Chaudhary and Milind for taking up this MAHA Speciality Connect. And they are been ably supported by people who had conducted in this last year by Samir and his team for MAHA Speciality Connect. So I told Shyam to and I requested Prashant to look after this along with the seasoned players. Prashant is more seasoned in all academics and IAP activities. But for the brevity of time and too many things, too much on his plate, so I requested him to delegate it to Shyam, who is also vice president of our MAHA IAP, and Milind, along with Samir and all these people. There is very little to talk about this program because program itself has spoken about it and the success about this MAHA Speciality Connect. And the theme is wonderful. We should take one single specialty and we should discuss threadbare and to the hilt of the situation. Rather than taking too many speakers, if we take less speakers, we could have a panel discussion on one particular topic. It is a good idea because MAHA IP has decided that newer and newer faculty should come to the fore. But at the same time, if we want real take-home messages, So we can have 2-3 speakers and then a good panel discussion by stalwarts of that specialty, subspecialty chapter. And one particular topic should be discussed threadbare. So people will have a good take-home message about it. So I request Prashant, Shyam Chaudhary, Milind and Samir to take up this suggestion, and next time we can reduce the speakers only for one-way dictate this lecture, but we can have a detailed panel discussion of 60 minutes, and with the stalwart of all subspecialty, whenever we are going to take MAHA Speciality Connect. So one moderator and 3 speakers, and it will definitely give a different flavor to this program. So I thank all the dignitaries who are to the present on this webinar today. Our Secretary Amol, immediate past President Dr. Hemant Gangulia, and who has been instrumental in conducting and paving the way for so many programs. And I thought it is the best way to give the benefit to all MAHA APN and who are academically thirsty people. And these names are already known to each and every pediatrician of Maharashtra. So we opted to continue the same name so people do not have to remember what it is exactly. So MAHA Speciality Connect. And I'm very happy that so many EBs have of MAHA AP. Sachin is there, Anurag is there, Dr. Jay, and our expert, Dr. Sanjeev Joshi is there, who is a very good friend of mine, a neurologist, Dr. A, and the speakers particularly, who are going to present us the topics. They will, I am very sure that they will be doing the justice to a short time allotted to them, and so many other things. But I welcome them, and I really appreciate the speakers who are all neurologists, Dr. Vishwanath Kulkarni, Dr. Prashant Utge, and we have got experts, Dr. Sanjeev, Dr. Anand Diwan. And thank you, Sachin and Samir, for being moderator for this session. And I wish all to these MAHA Specialty symposiums to be conducted in coming 9 more episodes. And I think you will take up this suggestion of having a panel discussion, and all subspecialty should be included into that. Over to you, Samir.
Samir, sir.
Thank you so much, sir.
Sachin, yes, over to you, Sachin.
Yeah. Thank you so much, sir, for your kind words. Definitely, we will take all your suggestions is forward. And good evening from behalf of Sachin Patil, myself. Now I request our beloved Secretary Dr. Amol Pawar, sir, for a few words of wisdom.
Thank you, Sachin. I welcome all the MAHA AP delegates for this webinar, all expert, both speakers, Dr. Vishwanath, Dr. Prashant, then today's experts, Dr. Sanjeev Joshi, Dr. Anand Diwan, sir, moderators, Sachin and Samir, sir, and all the OBs of Maharashtra IAP, Central IAP, EBs also. This is the first episode of season 2. Last year we have conducted it along with Dr. Jay Bhandarkar sir and Dr. Samir Sadavarte sir. Last year, for one session of X-ray, we got almost 3,400 viewers. The session was on X-ray, and the speaker was Dr. Ravi Ramkant. So it was the highest in numbers, in viewership numbers till date in MAHA's history. So this year also we'll be conducting another 9 sessions of MAHA Subspeciality Connect, and I request all the MAHA members to watch this and to gain some knowledge. And I also request Sachin and Samir and Dr. Prashant Jadhav sir to take all the experts from all the faculties for forthcoming sessions. Thank you, Sachin. Over to you.
Thank you, sir. Now I request Dr. Prashant Jadhav, sir. Jadhav, sir.
Thank you, dear Sachin. Respected Ramakant Patil sir, dear Dr. Amol, Dr. Hemant Gangolia sir, and all team of Maharashtra IIP and Central IIP. Warm regards to you. And as R.D. Patil sir said, that let us start this session 2 with a big bang. And I thank Dr. Sachin and Dr. Samir. When these two stalwarts are at the helm of the affairs, I am relaxed that definitely things are going to be perfect. And I wish everyone all good success, and we'll go to academics as early as possible. Over to Dr. Sachin. Thank you.
Thank you, sir. Milind sir is there? Milind sir? Milind Badia sir?
No, sir, he is not there.
He is
Okay.
not right.
Dr. Sham Chaudhary sir?
Sham sir is there.
Just a minute, Sham, just a minute.
Okay.
Madam, Dharmadhikari madam,
Yes, sir.
please try and communicate because already 100 participants are there.
Yeah, I'm
Last time
sending the message, sir.
it so happened that Milind wanted to join, but since
Okay.
already it was 100. So if there is you have enabled a waiting room, if he's there, you plus try and accommodate him. And
Yes,
how
sir.
can we communicate to others who want to join but are not
Okay.
able to? So how we can communicate to them that they can go for YouTube link.
We
For
are
seasoned players, it is
communicating them.
already, for seasoned people, it is already known. But still, if we could find a way.
Yes, sir.
Okay.
We are sending them messages.
Okay. Yes.
Okay.
Sham sir?
Good evening and welcome, respected dignitaries, faculties, experts, office bearers, and all the delegates on this virtual platform. As you all know, this is the first episode of Subspeciality Connect of this year and many more to come. I am sure each episode will be a great learning experience for all of us. I appreciate the efforts of dear Samir and Sachin for today's session. And thank you, Vishwanath sir, Prashant sir, Joshi sir, and Diwan sir for accepting our invitation as faculty and experts respectively. Seizure, such a common and important topic. I am sure this webinar will empower ourselves to tackle it with more confidence and more accuracy. Thank you and all the best. Over to you, Sachin.
Thank you, Sham sir. Now I want to introduce our expert, Dr. Anand Diwan sir. He is a diplomat of European Board of Neurology, diplomat of American Board of Epilepsy and Electrophysiology. Sir is the director of Narayani Hospital, Nashik, and is a well-known neurologist from Maharashtra. And now request Anand sir to have few words.
Good evening, everyone. Thank you for giving me this opportunity. I am equally interested to listen to the experts, Dr. Vishwanath and Dr. Udge, regarding the febrile seizures and how to investigate the seizures. And I think along with me, all participants will get equally benefited by the talks by these two experts. Thank you.
Thank you, Diwan sir. Now another expert is with us, Dr. Sanjeev Joshi sir. He has not joined. He is traveling. He will be there after 30 minutes. Sir is now Secretary of Neurology Chapter of IIP. Now the first speaker for today's session is Dr. Vishwanath Kulkarni sir. He is a MD Pediatrics from Ashwini Hospital, Mumbai. Fellowship in Pediatric Neurology and Epilepsy. He is an ex-surgeon, Left Commander, Indian Navy, and founder secretary of Maharashtra AOPN branch. Sir has various presentations. Now I request Dr. Vishwanath sir to start their session.
Sir, kindly unmute yourself.
Dr. Vishwanath, you have to unmute.
Yeah, can you hear me?
Yes.
Yes.
Yeah.
Please start your screen.
Good evening. Good evening, everyone. First of all, I would like to thank MAHA IP, Central IP for giving this platform to present today's talk on febrile seizure, what's new. So this is the most important topic as far as the pediatricians are concerned. You come across with febrile seizures day in, day out. Now, how to go about febrile seizures? How to categorize febrile seizures, whether it is simple, whether it is complex, and what are the recent guidelines about the same, that today we are going to discuss about the same thing. Now, I have took my references from AOCN, that is the Academy of Child Neurology Consensus Statement, ILE, that is International League Against Epilepsy, National Institutes of Health, and American Academy of Neurology. These are my references. Now, the first slide, the ILE defined febrile seizure that occur during the childhood after 1 month of the age. Now, remember this 1 month, you have to just keep in mind. When the child has febrile illness, there is no CNS infection and there are no previous neonatal or unprovoked seizure, and which doesn't meet criteria for other acute symptomatic seizures, is classified as simple febrile seizure as per ILE. Now look at just the age bracket, that is 1 to 60 months. I will come to it later. Now, what is the definition of febrile seizures by AOCN consensus guidelines? Now, febrile seizures are classified as seizures accompanied by fever, without any central nervous system infections, without any metabolic disturbances, or without any history of febrile seizures or any acute neurological insults to the brain. Now, simple febrile seizure without any focal component, which lasts for less than 15 minutes and which do not recur within 24 hours of duration, is classified as simple febrile seizure. The complex being the febrile seizures that are focal and those are prolonged for more than 15 minutes, or those which recur within 24 hours are classified as complex seizures. What is febrile status? The seizure which lasts for more than 30 minutes is termed as status. What is febrile seizure plus? The seizure which occurs out of the age bracket, that is, say, after 5 years, which occurs, it is termed as FS plus. And the last entity being the JEFS plus, that is the genetic epilepsy with febrile seizure plus. Now, the febrile seizure plus with family history of febrile seizures plus, or afebrile seizures like generalized tonic-clonic seizures, myoclonic seizures, absence, atonic, and focal seizures that are classified as JEFS plus. Now, as I told you in the first slide, now look at the ILA in the recent paper, they have categorized the simple febrile seizure that occur between 6 to 60 months. Initially, there were a few position papers which mentioned that it occurs between 1 to 60 months. But now, in the latest being 2016 paper, they have mentioned it is 6 to 60. American Academy of Pediatrics, they also, sing the same song between 6 to 60 months. The same with American Academy of Neurology, 6 to 60 months. While the NIH, that is the National Institute of the Health, they still classify the febrile seizure which occur between 3 to 60 months of the life. Now, coming all together, that AOCN guidelines, ILA guidelines, and AAP guidelines, we take 6 months to 60 months. Now, the seizure types less than 15 minutes, those are generalized, though those won't recur within 24 hours, and there is no post-ictal pathology. However, complex being more than 15 minutes, having focal component, they may have repetitive seizures, and you find present, then you term as complex febrile seizures. And febrile status that occur more than 30 minutes. So, coming to the epidemiology, febrile seizures are the most common neurological disorders of the infants and young children. They occur approximately 2 to 4% of the children younger than 5 years, and there is slight male preponderance as compared to the females. So, I won't go into the pathophysiology, detailed pathophysiology, how it occurs. So, we'll talk about most of the practical aspects of the febrile seizure. Now, what are the risk factors? Now, first of all is a high fever. Now, it is in much debate whether it is the maximum height of the fever rather than the rate of increase of the fever. But beyond doubt, it is the maximum height of the fever which is responsible for causation of the febrile seizures. A key variable that modulates the impact of the fever is seizure threshold, which varies by individual to individual and with age and maturation. Seizure threshold is lower for the infants and is modified by certain medications and water and say hyponatremia. The second risk factor is the infections. Now we know the viral infections are more common as far as the bacterial infections are concerned. Now, in this also, the HHV6 is most commonly observed virus in the Western countries. However, in Asia, we found more the influenza virus, which is implicated in the causation of the febrile seizures. The other viruses being adenovirus. Recently, we came across the COVID pandemic, and if you see on the right side of the slide, the 3.8% of the children with COVID-19 infection that had febrile seizures, 2.3 being admitted for non-febrile seizures, and almost 2 for the encephalopathy. The other viruses being respiratory syncytial virus, CMV. If you see the Shigella and rotavirus, generally it is more toxin mediated than the virus or bacteria itself. The third being immunization. Now, this is very important as far as the pediatricians are concerned. Now, if the parent come, my child received one vaccine and then he had febrile seizure. Now, how to go further? Whether to vaccinate or whether not to vaccinate. Now, there are a few vaccines like diphtheria, tetanus toxoid, and whole cell pertussis vaccine and MMR. Those are associated with more incidence of febrile seizure. But then again, it is depend upon the vaccine type, combination of the vaccines, genetic mutations, and the age of vaccination the child receives that particular vaccine. So you have to always see what are the risks versus the benefits. And as far as India is concerned, our country is concerned, the benefits of giving immunization, there are more than the risk involved. So we do not generally discourage the parents with febrile seizures and immunization. Another one is the genetic susceptibility. The children, they are having now more and more genes that are coming up, like for example, the febrile seizures that are implicated with long arm of 8th chromosome, chromosome 2q23. The trait is transmitted as autosomal dominant. Hippocampal abnormalities are identified in some patients and families with febrile seizures and may be a link towards genetic factors and risk of future temporal epilepsy. Developmental abnormalities of hippocampus like malrotation, including hippocampal malrotation, which I told, have also been reported in 10.5% of the children presenting with febrile status. Now, the other risk factors being the iron deficiency is also being indicated in causation of the febrile seizures. So, febrile status epilepticus, the seizure which lasts for more than 30 minutes. And this is the study, FebStat study, which is there. So what they say now, it is more important as far as there are a few kids who come with the complex febrile seizures and whether to get MRI brain done or not done. Now they observed that the children with febrile seizures, complex febrile seizures, and those who are subjected for the MRI, they find more T2 hyperintensities as compared to the other group. This is the again very important aspect, lumbar puncture, when to carry out. Now there are two recommendations. One is the AAP recommendation and one is the AOCN recommendation. So we'll talk about the AOCN recommendation. What Academy of Child Neurologists over India and consensus tells us. So children less than 12 months of the age with first episode of febrile seizure, especially if they have not received immunization against strep pneumonia and HIV, they should always subject for the lumbar puncture. Children more than 12 months who have been pre-treated with antibiotics should be, that is the cohort for vaccination. All children with febrile status epilepticus as the first presentation of the febrile seizure must be subjected to lumbar puncture. If the child's sensorium continues to be obtunded after sufficient time lapses, then lumbar puncture should be considered. And the last being, the lumbar puncture should preferably preceded by the neuroimaging in children with focal neurodeficits and if there are clinical symptoms and signs of raised ICT. So they have come up with crystal clear guideline about when to do CSF in children with febrile seizures. Coming to the neuroimaging. So if the child is having persistently abnormal neurological examination, focal features or signs, symptoms of raised ICT, go for MRI. Focal or prolonged febrile seizures, particularly those with history of abnormal development, because these children, they have higher risk of developing febrile seizures over the period of time. So get the MRI, and we recommend good 3 Tesla MRI brain done to look for the hippocampus and the abnormalities. What Eosin says? Eosin says all cases of focal or prolonged seizures, they must be subjected to the MRI neuroimaging within 72 hours, because those hyperintensities in the hippocampal region and those, then the Lewis et al., they are all, Chang et al. And Lewis et al., those were involved in the FEBSTAT. Those Lewis et al., he has observed that those children who had T2 hyperintensities within 72 hours, they presented with mesial temporal sclerosis in the latter part. So that's why the AOCM recommends to get MRI brain done in children with focal febrile seizures. Now EEG, again, very important. Once we see that there are many, we go for EEG, when to carry out EEG within 3 days, within 7 days. So many schools of thought then whether to carry out EEG or not to carry out EEG. What American Academy of Neurology says, routine EEG is not warranted, particularly if it is simple febrile seizure. Even if it occurs or recurs within 24 hours, by definition, it is a complex. However, it would not necessitate an EEG unless the neurological examination is abnormal. So if neurological examination abnormal, definitely subject the child for electroencephalogram. A prolonged seizure or one that has focal features warrants an EEG. The optimal timing of EEG is not really well defined. So whether I am supposed to get within 3 days or 7 days as per the American Academy of Neurology. However, what AOCN, that is Academy of Child Neurologists, says, so EEG may be considered in children with, complex febrile seizures. However, the prognostic significance of the abnormalities to predict the future epilepsy is still unclear. It may be considered among those children who are having abnormal findings on the neuroimaging. EEG, where it is indicated, should be performed within 1 week of the febrile seizure or at the earliest, as early as possible. And it should be as EEG protocol, minimum of 30 minutes, should be taken both in sleep as well as awake state. But to be very much frank, in pediatric age group and what we do, it is very difficult to obtain an awake EEG record less than 5 years of the age. Now we'll come to the management. So we saw the definitions, we saw whether to go for lumbar puncture, whether to do MRI brain, whether to go for EEG. Now let's talk about the management of those, what the current guideline says about the management. So if the seizures, they do end, if the child comes to you and he is not in, say, a particular seizure activity, the majority of the febrile seizures, they have ended spontaneously by the time the child first is evaluated and the child is rapidly returning to a normal baseline. In such cases, active treatment with benzodiazepines is not necessary. If seizure is prolonged, now the definition of the status, if the child is convulsing in front of you, operational definition is yes, the child is in status. So that no need for 30 minutes. Operationally, if the child is having seizure for 5 minutes, if the child is convulsing in front of you, the child is in status. So if the seizure is prolonged, so then if it lasts for more than 5 minutes, there is a recommendation of 2. One is the intravenous benzodiazepine, diazepam, that is 0.1 to 0.2 milligram per kg, or lorazepam, 0.05 to 0.1 mg per kg. Grade 1B is the evidence for the same. What about febrile status? Patients with continued seizures despite initial benzodiazepine administration should be treated promptly with additional anti-seizure medications, as are other patients with prophylactic and chronic use. There is general consensus that the risks of anti-seizure medication treatment outweigh the potential benefits in most of the patients. So do not go for any kind of prophylactic medications in simple febrile seizures. The effectiveness of anti-seizure medications was evaluated in a meta-analysis, and it was, while the treatment with phenobarb or intermittent oral or rectal diazepam was associated with reduced risk of recurrent seizures in the short term, that is between the 6 months to 2 years, it also associated with the risk of adverse effects in almost 30% of the cases. Now we know that the phenobarb is associated with the cognitive decline, and it caused permanent cognitive loss in the pediatric age group. So whenever you are giving phenobarb to these kids, think twice. The use of chronic anti-seizure medications or the prevention of recurrent febrile seizure is not associated with reduced risk of epilepsy. As for American Academy of Pediatrics, neither continuous nor intermittent anticonvulsive therapy is recommended for children with one or more simple febrile seizures based on the risks and benefit of the effective therapies. As far as eosine is concerned, intermittent prophylaxis is not recommended for the first simple febrile seizure. Intermittent prophylaxis with clobazam may be considered among children who are having frequent recurrent simple febrile seizures with parental anxiety. Those who are residing so far from the medical facilities, think about the intermittent prophylaxis in that subset. The drug of choice being clobazam, 0.5 to 1 mg per kg per day in 2 divided doses for maximum 3 days. If there is no need to taper this particular clobazam. You can directly stop after 3 days. Parents should initiate intermittent prophylaxis if child develops fever more than 38 degrees centigrade or when they administer antipyretic medication. Now we'll talk about the continuous prophylaxis. It may be considered among children. This is very important slide. When to give continuous prophylaxis in what subset? Number one, febrile status. Give prolonged or give continuous prophylaxis. Febrile seizures in children with neurodevelopmental delay. Second. Third one, frequent complex febrile seizures. And fourth, FS plus or JEFS plus with afebrile seizures. Think about continuous prophylaxis, and that to be sodium valproate. Once initiated, the anti-seizure medication should be considered for 2 years of seizure-free period. Okay, so that is the most important thing. Now there are only last two slides about risk of recurrence after the first initial febrile seizure. So almost 30% of the children, they do recur. So what are the risk factors for the recurrence? One is the age less than 18 months. Duration of the fever less than 1 hour before the seizure onset. First degree relative with febrile seizure and temperature less than 104 degrees centigrade. That subset is more liable to recur the seizures after the first simple febrile seizure. And what is the risk factor for future epilepsy after febrile seizures? What is this subset? So those who are having complex febrile seizure, those who are having family history of epilepsy, and fever duration less than 1 hour before the seizure onset, and those who are having neurodevelopmental abnormality, for example, cerebral palsy or hydrocephalus, they are more likely to have epilepsy after first febrile seizure. So I would like to give a take-home message that number one, the simple febrile seizures are more common. If they last for less than 5 minutes, if those are not associated with any neurological abnormalities in a child, do not go for intermittent prophylaxis nor for continuous prophylaxis. Investigations, EEG for simple febrile seizures, no. For complex febrile seizures, yes. Neuroimaging for simple febrile seizure, no. For febrile status, yes. For recurrent complex febrile seizures, yes. Go for neuroimaging to look for the T2 hyperintensity and further development of the mesial temporal sclerosis. And just you have to allay the parental anxiety as possible, because even though they find so frightening, the simple febrile seizures do not affect the development of a normal growing child. Thank you. Thank you, MAHA.
Thanks, Vishwanath, for this excellent program so far. You've done very nicely. We have a lot of questions, but we feel that we should take it afterwards. So next to Sachin again. Sachin, please introduce for the second speaker today.
Thank you, Vishwanath sir. Now the another speaker is Dr. Prashant Udge sir. He is going to enlighten us with the when to investigate a case of convulsion or case of seizure disorder. He is a pediatric neurologist, DNB HOD of Yashoda Hospitals, Hyderabad. He is a director of Udge Child Developmental Center, Hyderabad, Latur, and Nanded. He is a medical director of Umang Institute for Autism and Multi-Disability Research Center, Latur. Over to you, Prashant sir.
Thank you, sir. Thank you, Mahayati, Ramakant Patil, sir, Amol Pawar, sir, Sachin, sir, Samir, sir, and everyone. Is my screen is visible now?
Yes, sir.
So in next 15 minutes, even we'll try what is important to decide whether to investigate a single episode of the seizure or no. So just going towards what is seizure? Seizure, it is a just transient occurrence of signs or symptoms resulting from abnormal, excessive, or synchronous epilepsy. Obviously, it is the disorder that is characterized by two or more unprovoked seizures occurring more than 24 hours apart during the neonatal period. So, seizure is a simple single event, and epilepsy is a spontaneously recurring seizure. There are few definitions like some terminology like acute symptomatic seizures, unprovoked seizure, remote symptomatic seizure, or reflex seizures. We need to know of now the question is, do we really need investigation when we come across a single episode of seizure? So the question lies, are most of the things, if you being in a OT practice or in an inpatient setup also, the question is most of the time your clinical history itself give you the more diagnostic clue, and it will so we need to go from day one or from our medical school or even in a pediatric history and history is the major thing which will avoid your unnecessary or the investigation. We need to confirm whether the spell which has happened, whether it is a seizure or non-seizure, means it is a seizure mimics or seizure. And if once it is confirmed by the history, that has to be confirmed with the investigation. What type of seizure, as we are dealing with syndromic epilepsy, we need to categorize according to that. And then we need to find out the underlying causes for the seizure. So what is important according to, if everyone agree, being a pediatrician or being a pediatric neurologist, is the history. So what was the pre-ictal history, the ictal and post-ictal history is very, very important clue to go towards the investigation. So we need to ask the who has witnessed the event, that was the child has any, that is the aura. Child has given any warning signs, any lightheadedness or any flickering of the light in front of the eyes, any lip smacking movement or subabnormal movement. You agree with the previously we call it as abdominal epilepsy. There, so they used to describe some abnormal sensation in the abdomen and going up, or some fear sensation. That was the temporal lobe epilepsy which we correlate. So these are the kind of aura which we come across. So we need to ask person who witnessed this event, or if the child is able to answer the questions, we should try to collect the history from person information. And nowadays, and what was the child doing before the spell? How does it important? So what was the child like? If you take the example of the absence epilepsy, if child is continuously running and then he get the staring episode, means the hyperventilation has caused this. So while playing, child got the seizure, or while sitting, child got the seizure. Which position he got the seizure is very, very important. Second important question is diurnal variation. Shall be spending more time on the history because it is important, because most of the time we get our answer in the history itself. If the child get the seizure during awake or during sleep, to take the example of Rolandic epilepsy, if child get the seizure in the middle of the night or early morning and there is vocalization, that means the history itself will give, okay, I need not to go for any investigation. It looks like a benign type of epilepsy or a seizure. If it is awake during this stage and child gets staring episode in the school, or it is a daydreaming, that means are we dealing with the absence epilepsy or absence seizures. So it is very important to know what child was doing or whether child was awake or child was sleeping. If there is any history of sleep deprivation prior to the spell, was there any trigger for the spell? Let it be stress or a sleep deprivation or a child has tired. Once the child was well before the spell was, or there are the febrile illnesses, Dr. Vishwanath has clear-cutly defined the febrile seizure, febrile seizure. Now, the second question, ictal seizure. With the availability of the smartphones now, it's very easy. They try to definitely take the video and it gives us a information. But if the video is not available, then the information what we want is the was the child was responding during the spell or was conscious or consciousness is important. This is also important in categorization or a classification of the seizure. Did the child remember or there was during that spell or there was he forgot that episode? Any repetitive behavior during that episode, like lip smacking, pulling at the cloth, or constant rubbing of the object. So this is useful for the motor epilepsy. Did any body movement has occurred? Means whether this was atonic, tonic, or clonic seizure or a motor seizure. Was there is any perioral cyanosis? How long did the cell episode has the cell experience? So this will help you out to rule out like seizure mimicking condition like the rolling spells and others. Then now post-ictal history, how did the patient feel after the spell? Like if it is a simple syncope, child may feel some lightheadedness or some abnormal feeling. Did the child seem confused or tired after the spell, which is very common post-ictal stage in a seizure, but not very common in the syncope? How long did it take for the child to get back to the baseline condition? And did the child suffer from a headache after spell? More important in a child school going age is to know whether a child recover very well. Like most of the time, parents come to us that there is a complaint in a parent teacher meeting that there is a decreased attention of the child. He is not studying well. Recently, he is having the daydreaming, which may be usually confused sometimes with the absence stage. And the other question we need to ask a child had any febrile episode, any past history of symptomatic seizure in the past, and a family history. This will help us towards the genetic epilepsy and to correlate with the previous thing. So this is a notification in 2017. We won't go into the details, but what are the new changes in 2021? We need to know. So, according to ILA 2021 definitions, it is seizure types are focal, generalized, and non-etiological. Epilepsy types are focal, generalized, and combined generalized with like focal with generalized secondary generalization, and epileptic syndromes. And etiology, obviously, it's common in a structural, genetic, infectious, metabolic, immune, and unknown. There is very long list of that. Now, when you come across a child with seizure, what to approach or whether to investigate or not. So the most important point is the history which we have seen just now. So we need to decide whether this is a seizure or non-seizure non-seizure event or a seizure mimicking condition. Is it a stroke and when it is confirmed that is a seizure, then we need to categorize it as a stroke or unseizure, whether this is a focal or general seizure, what it is, so that we can give the process to the parents. Any associated comorbidities and treatment risk, anything they received in a previous and how we. So symptomatic seizures are caused by sinus infection, any acute trauma, cerebrovascular events, hypoxia, metabolic conditions, and neurological effect of the systematic diseases like any drug toxicity, drug withdrawal, which is very uncommon in like pediatric population, but tumors and congenital CNS malformation may be one of the like we come across very frequently the cortical dysphagia, Leiden-Cephali, and neuropathic syndrome. Tuberculosis is common, and typhoid illness obviously already discussed. Now, what are the differential diagnoses? As I said, we need to consider Caesar mimicking conditions. There is already the long list. I won't spend time on this, but definitely physical examination after clinical history is very, very important, because if there is a like temperature is high, we can correlate, okay, this could be one of the CNS infection or a febrile seizure causing this. If you come across the stunting or a failure to thrive, head circumference is low, microcephaly, we need to think in terms of childhood developmental delay, maybe underlying neuromigration defects, maybe underlying any metabolic disorders. Then we need to see the developmental history, very important. If a child presented with seizure, there is a developmental delay, definitely we need to go through the all investigation according to the protocol, but not in a child where developmental child is normal. We can wait in a single seizure. We need to find out any signs of trauma, sudden fall, and then child had so the signs of increased ICT. Everyone knows how to look for that, and in lesions, obviously the neuropathic markers are very, very important. Fundoscopy, yes, definitely being a pediatric neurology or in a acute setup, we need to look for any signs of raised ICT, which we can prevent it simple fundoscopic examination, identify and start it. Obviously, the neurological examination, if there is any focal neurological deficit, then definitely it warrants for the further investigation for that single episode of test. So what are the general tests we see is the complete blood count, sodium electrolyte, calcium, phosphorus, blood glucose, and magnesium. These are the primary screens where these are the immediate symptomatic seizure which can be treated. Others are like we need to see for any intracranial bleed. If you are suspecting an INR, PTT, and toxic ABG has to be done. And when you suspect there is a dysmorphism or a looks like something kind of metabolic disorder, then we need to move our direction towards the ammonia, lactate, pyruvate, and then the tandem mass spectroscopy. And then last remains the genetic epilepsy, where we doesn't find anything and we suspect genetic epilepsy, we need to move towards that. This one we I'll just bypass because differential diagnosis owns seizure mimicking condition everyone knows and we get ruled out. Now, whether to do the lumbar puncture in every child, not required in that, but the child is infant is less than 12 months with the first time febrile seizure, just to rule out intracranial infection, or even it's a simple febrile seizure and you suspect there are a few. This one I think already Dr. Vishwanath has covered. But if any child you suspecting there is a meningeal sign, we have to rule out the infection, and then the routine microscopic and the culture sensitivity has to be sent. Cranial USG, very limited role, but yes, in an emergency where you cannot shift the child to the CT scan or MRI, yes, there is a rule. There is a role of cranial USG to rule out any hemorrhages, any cystic abnormality or abnormal ventricles or raised ICT in a child with which can be visualized through cranial USG. CT scan, yes, there is a role in a head trauma in acute condition where you are suspecting bleed or severely hematomas. CT scan has the role. MRI indicated if you, as I said, either dysphagia or your focal neurological deficit, and there are recurrent seizure or a raised ICT, we have to find out any impending herniation. So MRI plays a major role in that. Now, important whether to do the EEG in every how does the EEG help it? Because this is the only investigation where we need to rely on a pediatric neurologist whether to go in clinical decisions. So EEG will help us to differentiate between epileptic and non-epileptic events. If the epileptic event seizure is confirmed on the EEG, then it helps to classify the seizure into particular epileptic syndrome. Let it be West syndrome, CSWS, or any particular benign epilepsy or absence seizure. It helps to quantify the seizure, localization of the seizure, and to see the response to the anti-seizure medication. Nowadays, we are not using anti-epileptic medication term. Usually now we are using, according to ILD, anti-seizure medications, especially in absence seizures, and to diagnose a non-convulsive status epilepticus following convulsive status epilepticus, especially in the ICU setting. So when EEG is abnormal and suggests the nature of the seizure, whether this is a focal or generalized, but does not determine whether this fails or seizure or like whether to treat or not. To give the example, 1 to 2% of the non-epileptic events may have the spike. So in their EEG. So do we need to treat it? No, we need to confirm on the clinical judgment and then correlate EEG with that. 20% of the patients with spike on the EEG do not have the epilepsy. To give the example, if you order suspecting sitting in the OP, that child is getting the repeated absences or staring look, you are suspecting that there is a three spike wave heard on EEG. But if you order the investigation and you come across the EEG report has come completely normal. So you need to check it whether the EEG has to be done in a proper setting, like whether they have done the hyperventilation, whether they have done the photic stimulation, which will show the three spike wave pattern, which may not be like observed if the technician bypass that procedure. So we need to aware when you are ordering the investigation, please try to communicate with the reporting station and whether the procedure has been followed or not, or the particularly like photosensitive epilepsy, we have to go for the photic stimulation.
Prashant sir, you are mute. Prashant sir, you are mute.
Sorry. Now audible?
Yes,
Yes.
sir. It will be bit louder, then it will be better. Bit louder.
Yeah. So, as I said, EEG ordering investigation is not the only job, but we have to correlate with the EEG and clinical picture and the reporting neurophysician and pediatrician need to communicate, because sometimes because of the hurry, as Vishwanath said, ideally yes, EEG has to be done sleep as well as awake, and 30 minutes record has to be done. Photic stimulation and hyperventilation has to be done, which usually sometimes in a hurry they may bypass. So we need to correlate. So ultimately, the what should be the management strategy? First, we need to confirm whether this is a epileptic or non-epileptic event. Then establish the diagnosis of syndrome, whether this is a syndromic epilepsy or generalized epilepsy. Need to evaluate whether to start the treatment or not, and then obviously the drug of choice, start on the monotherapy and switch over to the polytherapy if child is not responding. Is it moving? Yeah. So just I'll finish within smart, small two cases. This is a 12-year-old boy, developmentally normal, studying in a 7th class. Seizure onset at the age of 4 years. He had 2 episodes of generalized clonic convulsions, and then was taking Tegretol, started by the physician. Later stopped with that Tegretol, child has stopped seizures, but according to the uncle. But then again, like slowly child, this was the history given by the uncle. But when we go into the details of the history, in fact, after starting the Tegretol, seizure episode has increased a lot. So anyone want to just say what is the diagnosis in this child, just for the interest of this one? So and what investigation we need to do it in particular? One investigation if you give it, what is the drug of choice and what are the bad options for this? So the drug of investigation in this child, as we are suspecting absence epilepsy, we did the EEG and we confirm our diagnosis on this. So in this case, do I need to go for MRI? Usually no, because this is a syndromic epilepsy, which is idiopathic general epilepsy, will go off over the period of time with the proper treatment. So absence epilepsy, as you know, it is starting is 4 to 10 years, and there are multiple episodes. Sometimes maybe taken it as a daydreaming by the teachers or parents, and the classical EEG shows 3 hertz generalized spike and wave discharges. And usually they respond to the sodium valproate. Itolizumab is the drug of choice, but definitely it is not widely available. We should be aware of others. But what we should avoid in a child with absence epilepsy is the phenobarbital, carbamazepine, oxcarbazepine should be avoided. Now, do we have the time? Hello?
Yes, sir.
Yes, you can have 5
Yes,
10
sir.
minutes.
Go
Okay.
ahead.
5 minutes.
No
Okay.
Yeah.
Okay. So one more case I'll be sharing very commonly. 8-month-old boy, non-consanguineous marriage, cried immediately after birth, no NSU stage, so no history, significant history of hypoxia. And child suddenly started to have the jerking movement, especially the infantile spasm. Child started with excessive cry, irritability, and there is progressive regression of the cognitive function. So in this child now, as the hypoxia is not there, non-consanguinity, so the investigation which we did is the EEG, and it has turned out to be West syndrome, hysterectomy. So now, what should be the investigation, next investigation of choice? Obviously, on the clinical thing, it has confirmed that the infantile spasm and clinical examination showed cafe spots, and the EEG confirmed with the hips arrhythmia, and this was the picture. So, what is the investigation of choice in this child? Is it a MRI or CT scan? In this child, simple CT scan may give us a tubers, which will help us, and we can avoid going for the MRI brain. And the simple CT scan may give you the diagnosis, but has to be confirmed in a long run with the MRI. So MRI, you can see multiple tubules developing in the picture. So gradually started with Sabril, and for this one, within 5 days, it has clinical seizures, infantile spasm has stopped, and EEG, which we have seen after giving the vigabatrin, has turned out to be normal. Other treatment, I won't go into the details. So thank you everyone. I'll stop here with the common investigation. I'm purposefully not going towards the genetic epilepsy and metabolic workup because this is the needed clinical correlation with the and what to order. Thank you. Thank you.
Samir, sir, go ahead.
Yeah, thanks, Prashant, for this excellent talk. And we have now our co-host with us, and also the experts today, Dr. Anand Diwan sir, and also with us, Dr. Sanjay Doshi sir. So I'll request Sanjay Doshi sir, please put your experts' comments, and Dr. Anand Diwan also.
Hello, everyone. My sincere apologies that I joined late because of my unplanned, unscheduled travel this evening. So my humble thanks to the organizers, Maharashtra IP, Sachin, Samir, of course, the duo of Ramakant and Amol, and our two young dynamics of pediatric neurology, Prashant and Vishwanath. Unfortunately, I couldn't listen to Vishwanath, but definitely I could hear Prashant. So what I could gather, there are 2-3 comments which I will make, that when you evaluate a seizure, a comprehensive history is very essential. Another thing is, when apart from the history, if you have a something like a video, it speaks a lot. And percent of the time the epilepsy is overdiagnosed. So you have to differentiate between a paroxysmal event, whether it is an epileptic or non-epileptic. That is one point. Another thing is, when you approach to a child of seizure, the most two important thing in the when you start working up is EEG and neuroimaging. So I would like to ask Prashant, if I say that EEG is diagnostic of epilepsy, would you agree with me? Prashant?
Sir,
is EEG diagnostic of EEG?
No, sir. As I mentioned,
it's not so EEG, very good. EEG just support the diagnosis of epilepsy. EEG will help to define an epilepsy syndrome. Okay. Yeah. Another thing is the judicious use of neuroimaging. Prashant, you have a electroclinical diagnosis of an epilepsy syndrome on the EEG. And would you like to go ahead with neuroimaging still, or you can skip neuroimaging?
No, sir. When it is clear cut showing the benign epilepsies or absence epilepsies, obviously we can come down on the financial burden of the patients.
Okay. And another thing about EEG is that you have a child, for some particular reason, he underwent EEG. There was no any clinical history of seizure. And the epileptologist or the whatever, whichever person has done the EEG, reported there are few centrotemporal spikes. Are you going to treat that child, or you will just wait and watch and follow to this child?
Sir, here I'll take 1 minute for everyone's interest. Sometimes a child come to a pediatric OP with simple excessive cry, and the same baby comes to us. We go for EEG, and pediatrician obviously we think with the colleague and everything. So sometimes in such situation it's justified. But if the epileptologist does the EEG, there are no clinical seizures, and suppose it turn out to be abnormal EEG, should not be treated, because we need to primarily confirm our clinical history, examination, and then go towards the EEG. We should not treat the EEG isolated report.
So very, very important message from Prashant, that unnecessary subjecting unnecessary subjecting to the child to EEG is highly irrational. Okay. Now the third thing is that when you have started a treatment without doing any workup, and the child suddenly deteriorates on that particular clinical situation, how would you look for that particular situation? Are you dealing with some the seizures which are precipitated by that wrong medication or something like that?
We cannot say wrong medication, sir. To take the example of, suppose Rolandic epilepsy, recurrent seizure, and we start on carbamazepine or carbamazepine. So there is a possibility, a known side effect, that there is a cognitive decline and there is a worsening in a EEG as well as.
No,
so
basically, no, Prashant. I'm talking you a situation which has been aggravated by that particular anti-seizure medication, like a child treated with generalized tonic seizure, without going into detail of that history, without doing person, and then later on it was found on probing the history that he used to drop objects in the early morning hours. Then he had broken some plates also of the household, and then after probing this history, the child was subjected to EEG, and then the classical syndromic diagnosis was made. So what is the message about this situation, Dr. Prashant?
Sir, in such situation, as I said in a protocol, drug of choice, monotherapy, is very, very important. And your clinical history, what you narrated, itself is the diagnostic, will be confirmed on the EEG. And then we need to start the broad spectrum antiepileptic rather than starting the other drugs.
So this child had complexes of polyspike wave. So the diagnosis was juvenile myoclonic epilepsy. The myoclonus was made worse by the use of carbamazepine. Okay. So the point is that whenever you start treatment, at least have some or other detailed semiology description, the comprehensive history. There is no any shortcut to a comprehensive history in neurology. I think both of the experts, all of you must be agreeing with that.
Yes, sir.
Thank you.
Okay. I think Sachin, I think it is.
We are with us also Dr. Diwan sir also. Sir, expert comments for this, both the cases, sir.
Yes.
Diwan sir, please go ahead.
Yes. Congratulations to both the speakers for covering both the topics extensively and very nicely presented. Few comments. I think Dr. Vishwanath Kulkarni has covered very well about the febrile seizures, and the first few slides mentioned very well about the age of syndrome of febrile seizures from different platforms mentioning different age categories like 1 month to 60 months, 3 months to 60 months, or 6 months to 60 months. When it comes to our day-to-day clinical practice, I think age and number of seizures, number of febrile seizures is very important to treat those babies as a just simple febrile seizures, or they are really epilepsy which are just triggered by the fever. I take a point where, as per the literature says that majority of these febrile, simple febrile seizures or complex febrile seizures altogether happens in almost 90% of the babies between 18 months or to 24 months or less than 3 years. So there are only 10% babies who develop seizures below 6 months or after 3 years. So whenever a baby comes with a first febrile seizure after 3 years, I'm little worried that this may not be just a simple febrile seizure.
Yes.
And the type which the way which we are differentiating simple and complex febrile seizures is just to predict the future risk of epilepsy. It is not the risk of recurrence. Both simple febrile seizures and complex febrile seizures will have a recurrence risk is almost same. After the first event, the risk of recurrence for the second event is almost 30%. And after 2 events, the third event will happen in almost 15% or less than 15%. The more than 3 febrile seizures are very less likely to happen, and that is less than 5%. So if you get a history, a baby which is just 2 years, but mother says he gets seizure every monthly with fever. He has got almost 4 or 5 seizure attacks with fever for last 6 months or within last 1 year. So this is really odd history. This is not just a febrile seizure, but this is nothing but a epilepsy. If we investigate further, we may found some genetic reason behind it. But a rule of 3, which I would like everyone to remember, is if it happens after 3 years, 1 or 2 seizures with fever, or if it's more than 3 seizures of febrile events, then it is more likely epilepsy and not just a febrile seizures. And there we should have a low threshold to start prophylactic anti-seizure medications. Again, all the platform doesn't mention whether neurologically normal or abnormal baby is likely to get febrile seizures. So even if it's developmental delayed, child can have a febrile seizure. So there is another one caveat or controversial point: if child is developmentally abnormal and gets a febrile seizure, should we treat or we don't treat if it's just for simple febrile seizure? Regarding a second talk about Dr. Prashant Udge's, the how to investigate, and we all, as a clinician, we always say that the best 3 tests to confirm whether it's epilepsy or not: first is history, second is history, and third is history. So everything is based on history, and only after history we should go ahead with the investigation to confirm or rule out whether those paroxysmal events is really epileptic or not, like EEG and MRI. Again, reading those EEGs by a trained neurologist or epileptologist, and again reading of those MRI by a trained radiologist is very important, because most of the EEGs are over-reported as abnormal. And in my personal experience, I see almost 60 or 70 or more than that the epileptic patients who have a normal EEG, normal MRI, and it's very difficult to convince the parent that this is epilepsy, though the investigations are normal. So that's my personal comments. Thank you, MAHA IP, for giving me this opportunity once again. Thank you.
Thank you, Diwan sir. Definitely, we will follow your rule of 3 in our day-to-day practice. First of all, I have to introduce our observer, respected Dr. Rajendra Kulkarni sir. Sir, we are eager to hear some words, few words from you. Dr. Rajendra Kulkarni sir.
Hello.
Yes, sir. Yes,
sir.
sir.
Good evening, sir.
Welcome,
Yes,
sir.
sir. You are
Good
audible.
evening. Good evening, everybody, and I congratulate my IP team for successively conducting very important and clinically important topics in this CME. That is a very welcome step and good initiative by our dynamic president and secretary, Dr. Ramakant and Dr. Amod. This is a, I think whatever I gathered, I joined a little late, but what I gathered and the underlying point is history, history, and history. That is the crux of this neurological presentation, I suppose. And both the speakers have enumerated, and of course the expert comments by Dr. Sanjeev Joshi and Dr. Anand Diwan, they also underlined the same, and it's very useful. I congratulate and wish you all the best for the coming tenure and with such important, clinically relevant and practically important topics. Thank you. Please go
Thank
ahead.
you. Thank you, sir.
Thank you, Kulkarni sir. Any
Thank you,
questions in
Maharashtra
chat?
IB, Ramakant, Amol, Samir, Sachin. Thank you. And
Yes, sir. Thank you, Sanjeev sir.
We have
Thank
just
you, sir.
finished. We have
again, my
some
You
sincere
are
questions
joined
from the
at
audience.
proper timing.
Sanjeev, before you leave, we have got few questions for all of you. Vishwanath, Prashant, Anand, and Sanjeev also. What is your individual take of intermittent paracetamol and clobazam for prevention of febrile seizure, or only intermittent diazepam or midazolam as a rescue rather than an intermittent this thing?
Yes, sir. Can I answer this?
Please
Now,
go ahead.
the intermittent paracetamol, it is no role in reducing the seizures or something. It is very well said in the consensus statement that it will reduce the discomfort to the child by giving 6 hourly paracetamol. It won't reduce the risk for developing a febrile seizure. That is one thing. Second one, if the child is having only one first episode of simple febrile seizure, do not go for intermittent prophylaxis. If the child is having recurrent episodes of simple febrile seizures, if the parents are anxious, and if they reside far from the medical facility, then think about intermittent prophylaxis with clobazam. That is 0.1 to 0.2 mg per kg per day in 2 divided doses for 3 days. There is no role for continuous prophylaxis. Now, the last question which you have asked, sir, the midazolam and diazepam, isn't it, sir?
Yeah.
So midazolam, the diazepam, the rectal diazepam is also been recommended, but it is availability is very poor and it is very messy. So it is better to give intranasal midazolam sprays which are available. And what we do generally, say per 5 kg, 1 puff in each nostril of 5 milligram of per ml. That is very easy to remember while doing the practice. So if the child is 10 kgs, 2 puffs in each nostril. If the child is 15 kgs, 3 puffs in each nostril, total 6 puffs. So it is very easy to communicate with the parents and very easy to give it.
And Vishwanath, one most important thing is there are 2 strains of intranasal midazolam spray available.
Yes, there are 2. So if the child is bigger, then I go for 12.5. If the child is small child, go for 5 milligram per ml.
About another thing, Ramakant has pointed out that about midazolam. Now, the latest evidence says from the American Epilepsy Society that intramuscular midazolam is having level A evidence for acute seizure control. So, my message to all the attending pediatrician, if you don't have quick access to IV, don't waste your time. Give 0.2 milligram per kg of intramuscular midazolam, and it has got a very, very good effect, a very nice effect. But of course, whenever a child with febrile seizure comes to you, you must teach as Vishwanath has already elaborated how to use the intranasal midazolam spray. Okay. But if the child is coming to you, convulsing to your OPD or your emergency room, if you cannot establish an IV access, don't panic. Give intramuscular midazolam. Will be my message. Ramakant.
Anand.
Yeah, I agree fully. The basic dictum is hit early. So whatever is available, hit early. So midazolam, if can be given intramuscular before IV access, it will be definitely effective or better effective than wasting time in getting IV access and then giving IV lorazepam. So whatever comes first is a better option. So midazolam here is definitely better than. For me, the rescue therapy will be definitely nasal midazolam spray.
Yeah.
And the prophylaxis, I consider more than, as Dr. Vishwanathan said, more than 2 simple febrile seizure or even 1 complex febrile seizure, I will consider prophylaxis for the next event.
So consensus is there that there is no role of paracetamol in preventing a febrile seizure.
Yes, it's just to comfort the child.
Yeah, it will be just reducing the discomfort.
Correct.
Yes, sir.
Thank you, sir. Another question is, some questions are there. Are the blood investigations are important in the case of febrile conversion, especially ionic calcium and magnesium?
Answer is no.
Oh,
Straight. Again, consensus. There is no reason to get ionic calcium and the magnesium in those cases.
When we should repeat the EEG in a follow-up patients? Are there any indications to repeat the EEG?
The question is whether to do EEG first.
Yes, sir. Yes, sir. So,
And then the second question is whether to repeat or not.
If on EEG diagnosis is done earlier and patient almost 12 months to 16 months are over on anticonvulsant, doing well.
Okay. So
should we repeat
after 2 years of seizure freedom, I prefer to do repeat EEG before stopping the medications. 2 aspects, one medical legal and one definitely the data shows if EEG is still showing abnormality after 2 years of clinical seizure freedom, there are risk of getting the recurrence of seizures. So there I again continue with the anti-seizure medication for maybe another 6 months or 1 year and then repeat EEG and then decide whether to stop or not. But I do repeat EEG after 2 years of medications. There is no standard guidelines for this, but there are calculators which mentions depending on the age of onset, number of seizures before starting antiepileptic medications, the MRI abnormality, and the EEG after the course of medications. With and without EEG, if we stop, what will be the recurrence? Then all data favors if we do repeat EEG, it's beneficial to take a decision whether to stop or not.
I think there are certain variables which will decide whether to do repeat EEG or not. Like if you are dealing with an epilepsy syndrome, or if you have a semiology which is showing multiple types of seizure, and then you have some neurodevelopmental issues. And the best example of assessing the response to the treatment is the case of hips arrhythmia. If you have a complete reversal after the adequate dose of ACTH or whatever, so repeat EEG is very useful. Prashant, please.
Yeah, sir. Especially the syndromic epilepsy like hips arrhythmia, response to ACTH, response to your vigabatrin. Then, as I mentioned in my presentation also, if it's absence epilepsy, you start on a valproate to see the response. We need to repeat it before we stop the sodium valproate. So there are few indicators where we need to repeat it.
Can I add one thing, Dr. Sachin?
Yes, sir.
Yeah, now it is not only about only the treatment response, but there is one condition which is tuberous sclerosis, where you put the child on EEG surveillance. So before starting the clinical seizures, you want to get EEG to see the electrical discharges. So it will help you in give the precision therapy to those kids with tuberous sclerosis. So it is okay. That's okay when you want to get it. But now this EEG surveillance, it is coming to the home. It is very nice one.
Yes. Thank you, sir.
Sachin, so we get the impression that for garden variety of epilepsies, other than those who are in the domain of neurologists, we did not do EEG repeatedly at least.
Yeah.
Rightly said by Anand, we have to decide when to do first EEG. And there is no question of saying that is a domain of neurologists and not general pediatricians. I got one more question before Sachin, you go to the spree of questions which are from the chat box. We are really worried for Sanjeev and Prashant and all these things. What should be the second line antiepileptics? Should it be fosphenytoin, phenytoin, phenobarb, or levetiracetam or valproic acid? Which will you individually using it? What will you recommend?
Sir, usually broad spectrum anti-epileptic anti-seizure medication is the good one. If there is a no financial constraint, obviously the levetiracetam will be the one of the good option.
We have given midazolam or intramuscular. This is not. Now I have to use second anti-epileptic. Which I should choose?
Ideally, sir, fosphenytoin. Ideally, it should be fosphenytoin if it's available because it's easy to give. Nowadays, individually, we are actually levetiracetam. I'll be personally using it at very ease rather than using phenytoin or fosphenytoin. Better, usually, I prefer it is individual, but according to the protocol, obviously, we need to follow with phenobarbital, fosphenytoin, and then levetiracetam.
Ramakant, the simple single liner is there is evidence to choose either of the three second line drugs, valproate, levetiracetam, and fosphenytoin. Whatever is available with you and whatever you are comfortable with, I think you should try first in adequate doses. Don't give fractional doses, as Dr. Diwan has already put it. Hit early and hit hard. That should be the dictum. I will agree.
Hello,
Yeah,
voice is breaking.
Hello?
Sanjeev, your voice is breaking. Probably connection is you put up the video. Probably so your voice will be heard better.
Okay.
All three second line drugs are almost equally efficacious: levetiracetam, fosphenytoin, and sodium valproate. Data says little bit superiority of sodium valproate, but as per the ease and the brevity of side effects, I prefer levetiracetam over the other two, like phenytoin or the sodium valproate. Even for phenobarbital can also be substituted. So we have a choice, one amongst the four drugs. And if that fails, then we'll go ahead with the midazolam infusion or pentothal infusion.
So what I feel that levetiracetam is causing a death knell on phenytoin or fosphenytoin. Probably.
Yes. So actually, it's called like it's a old drugs. Like suppose senior pediatrician, senior neurologist, he will prefer phenytoin, phenobarbital. Like a new neurologist, he will prefer levetiracetam. I think so. It may not be correct, but as mentioned, we have to give full dose, as mentioned by the Joshi sir. What happens? People give 10 mg or 20 mg, wait for long, and then patient goes in status epilepticus. So one drug finish complete dose. Like suppose for you are using levetiracetam, the full dose will be 60 mg per kg. Am I right? Or
Yes,
is it like that we give 15 to 20 and then switch to different? No. We should complete the full dose. That is the best treatment, particularly to prevent the status epilepticus.
Correct.
Yeah.
Sachin.
But please, one important statement. Don't use levetiracetam as a first line drug. The first line is benzodiazepine, and benzodiazepine.
Yeah, that's true. Second line is what we are speaking about. First dose is always phenobarbital. First dose is always like using midazolam, lorazepam, all these ones. Like a second line drug. That's what our debate was.
Sir, now we will go with some rapid fire questions. I think time won't permit us. I think 5 minutes are remaining. Last. Pallavi ma'am, how much time?
We can have, I think so. If people are enthusiastic talking
time you decide, Sachin.
I have one question about the drug levels. Like what and whether you want to do drug levels. Because that is called as one of the commonest reason that people stop giving medications, the drug level goes down and patient goes in status epilepticus. So like before finishing that one, I feel personally that we should go ahead for doing the drug levels particularly. What the experts comments on this?
I rarely use, if I can answer, I rarely use the drug levels. I go by clinical. I don't see whether toxicity is because of the drug level. If patient is complaining the side effects, then irrespective of the drug level, even if it is falling into therapeutic range, I will try to reduce the dose. And only condition where I will consider drug level is when I'm checking for compliance. Patient is saying he's taking the drug regularly, religiously, and still the patient is getting breakthrough seizures, and I'm suspecting that he's not taking the drug. And just to check whether he's really saying whatever he's taking drugs is correct or not, I check the drug levels. So for me, only two indications, just to check his compliance by seeing drug level, and to see if not the second condition, but if he's getting toxicity, then just to confirm if it's in toxic range and to reduce the dose. But even if it's in the normal range, I will still reduce the dose if it's having the toxic side effects of the drug. So I hardly use the drug levels. And for new drugs like levetiracetam, lacosamide, lamotrigine, we don't have any therapeutic drug levels available. Yeah. So only for sodium valproate, carbamazepine, and phenytoin, phenobarbital, we have the drug levels.
One question is there from chat box. First episode of simple febrile convulsion, admit patient. What are the investigation to be advised?
Just look for the focus of the fever. That's it.
Look for the cause of fever.
Cause of the fever. Finish. No other investigations.
Why did you admit it? Why did you admit it?
Absolutely.
That is the question.
So that is a very tough question to answer actually in one line.
No, that is parental anxiety, and it's most
coming
of the
late at night. Yeah, coming late at night is usually the indication to admit.
Anand,
yes.
Are there any cues which will suggest us this febrile seizure could be a Dravet syndrome? And
first,
are we more aware because we are becoming diagnosing more, or it was existing from time immemorial, that because we are now more aware or more experts are there? And can we really send the gene for Dravet syndrome cues initially?
First febrile seizure is really difficult to say whether it was just complex febrile seizure. Usually those are complex, more than 15 minutes. And usually hemiconvulsive seizures. If that is happening, we can just, at the first event, we'll say it's a complex febrile seizure.
No, Ramakant, this is very difficult to answer. Indicators like consanguineous marriage, the family history of fever-induced epilepsy, and then definitely you have to follow up that child.
Yes.
Yeah, so for first event, it is difficult. Yes, definitely if it is happening recurrently, just less than 6 months or immediately after 6 months, and even with the low grade of fever. So prolonged multiple complex febrile seizures, will definitely consider Dravet syndrome as one of the differentials rather than just complex febrile seizures. Because as we said, the complex and simple febrile seizure differentiation is to predict the risk of epilepsy, not the recurrence of febrile seizures. So even if it's a complex febrile seizures at first time, there is no need to recur per se. So when it is recurring, it is likely epilepsy or Dravet syndrome if it happens second time or third time, if it's a complex febrile seizures. So only those conditions will consider Dravet, or we will send SCN1A gene study.
Along with some febrile episodes also.
Yes. Febrile or febrile, prolonged hemiconvulsive, prolonged hemiconvulsive.
Yes.
Each usually will not pick up the first time.
No, EEG will not pick up. Even neuroimaging will not help.
Will not pick up. Yes. Yes.
I have one question rather than. Oh, sorry, sir. Go ahead, please.
High index of suspicion when you have some red flag sign like a positive family history, complex febrile seizure. And there is one more indicator: if somebody has inadvertently put their child on carbamazepine and the child or phenytoin and the child worsen, it is definitely your history, your clinical scenario is pointing towards something like Dravet. Okay.
And that's why our first choice, second choice is levetiracetam over phenytoin and phenobarbital.
Yes.
Sachin. Samir sir, want to say?
Yeah, I have a question or rather a comment actually, because parents have a lot of psychological impact on the seizures, And sometimes we also know that most of the patients who get febrile seizures, they are also having some issues neurological. And in long term, they can have cognitive and memory impairments and some other neurological issues. And they always blame it on the first pediatrician or on the first person, like first conversion then comes. And we always say, no need to give medications, no need to do ECG, EEG, no need to do MRI. And subsequently, such kids, some unfortunate, they get some
सकाळी
epilepsy.
तुला 4:30 वाजता यावं लागेल मला घ्यायला 4:30 ला.
So in such cases, how to counsel the parents? This is most important, particularly when the first time episode happens in the seizures in any child, and how to conclude on this part. So I want to know what we should give advice to the parents with this.
We said that
Hello.
what was exactly following the guidelines, and as it has happened second time, then we'll now consider the investigation or if needed treatment. But this is according to the guidelines which is followed, and you have the previous doctor has done the correct job as per the guidelines. That's how we can consider.
Samir, whatever the evidence says that the simple febrile seizure going for epilepsy, I think Vishwanath must have told that it is just 2%. Even 1%, there is a risk of epilepsy in general population. So the risk becomes 2% in a child with simple febrile seizure. Another thing, there is only one temporal relationship. Both these two colleagues or three colleagues, they must be agreeing that if you have a febrile status like situation, then you may have something like mesial temporal sclerosis in the future. So that is only the temporal relationship, and then those kids has to be followed up. Of course, febrile status you won't live without any treatment. So these are the only things which are documented. Otherwise, but Samir, the most important thing in a child with seizure or child with epilepsy is counseling of the parent. You should take away the fear from the parents. You should teach them how to treat the rescue teacher at home. And you should always counsel them that don't panic. Even if your child is seizing, he's still his respiration is still intact. His vitals are still that even if you treat unprovoked, they are not going to prevent epilepsy in the future life. And also the long-term morbidity and mortality.
Okay.
Hello. Yeah.
Thank you, sir. Almost all lot many questions are covered.
A last question is there because somebody has asked that question. What about the head injury? Like after head injury, should you give prophylactic anticonvulsants or you should not give? And if you want to give, for how many days? 7 days versus 6 months versus 2 years, because all the things that's been seen documented by various pediatricians. So for the simple pediatricians, what will be the take-home message for this, particularly after head injury, which is minor or major type?
There is no role of prophylactic antiepileptic therapy even after head injury. If head injury is severe in a form of hemorrhagic contusions in temporal lobes or significant diffuse axonal injury, where a child is altered and you don't have access to EEG as a correlate whether it's seizures or not, or non-convulsive seizure or not, there you can give the anti-seizure medications. But the dictum is you stop anti-seizure medication at the time of discharge or maximum 7 days. The continuation of anti-seizure medications beyond that time is not going to prevent future epilepsy, even if it's going to happen as a scar epilepsy or remote symptomatic epilepsy. So dictum is no prophylactic therapy. In a significant severe injury, you can give it for not more than first 1 week or till the time of discharge. And if there are no seizures, you can just stop it immediately.
Okay.
Thank you, sir. Almost since last 1.5 hours, we are hearing the neurology saga. Now it's the end point. Now I request Dr. Amol Pawar, sir, Secretary, MAHA IP, for the vote of thanks. Amol, sir.
Yes,
over to
yes. Thank you, Sachin. First of all, thank you both the experts, Dr. Anand Diwan sir and Dr. Sanjeev Joshi sir, for guiding all of us regarding these seizures. Then also speakers, Dr. Prashant Udge from Hyderabad and Dr. Vishwanath Kulkarni from Pune. They have taught us the febrile seizures and what to do when seizure patient comes to you. So which investigation to be done and justification for that. So I thank all the office bearers of Maharashtra IIP, EB members of Maharashtra IIP and Central IIP as well, and all the delegates for their kind listening to this session. It will, the post session link will be available soon. So those who have missed this session will then they will have this access of this post session link and they can again watch this session in their free time. Thank you, Dr. Samir sir and Sachin Patil also for moderating this very important neurology webinar. Thank you, Neha. Thank you, Vishal, for their flyers and messages. And thank you, Pallavi ma'am, for backup support. And thank you, coordinators of this session, Dr. Prashant Zadav, Dr. Sham sir, Dr. Milind Baradia sir. Thank you, one and all.
Thanks all. Thank you very much.
Thank you. Thank you.